Hello. In our second part of the musculoskeletal disorder series, I'm going to be talking about osteoarthritis, rheumatoid arthritis, gout, osteomyelitis, and musculoskeletal tumors. Starting with osteoarthritis. The osteo is bone, arth part is joint, and itis is inflammation. This is commonly referred to as OA for short, and I'm sure you've heard of it before. OA is the most common form of joint disease and the leading cause of disability in those that are middle-aged and those of older populations. Currently, there is no single specific cause of osteoarthritis. Historically, it's been viewed as this mechanical problem, and there is emerging evidence that suggests that there is evidence of various different molecular events that are occurring that interact with mechanical stressors and mechanical issues. Osteoarthritis often occurs without a known precipitating cause that just occurs with aging, and so that's known as idiopathic or primary OA. In other cases, osteoarthritis can develop because of exceptional stress that places on joints. So rather than it being related to just age in itself, exceptional stress on joints can occur because of those that are obese. I spoke about in our in-class lecture when we talked about osteoporosis about how people that are overweight or obese have stronger bones. So they have more bone density because their excess weight really acts as a form of weight-bearing exercise, carrying it around. However, this excess weight puts a substantial amount of stress on the joints. Many joints throughout the body, but certainly the ankles, knees, and hips will experience a lot of that stress. And so people that are obese, while they have lower incidence of osteoporosis, would have higher incidence of osteoarthritis. And then certain athletes, gymnasts, long distance runners, can be predisposed to developing osteoarthritis in certain joints. Now, the progression of osteoarthritis is usually noted in a few joints. So for example, somebody might have one or both of their hips, or maybe one or both of their knees that are affected by osteoarthritis. In other cases, somebody may not just have a few areas that have osteoarthritis, it could be more generalized, but oftentimes the progression is noted in a few joints. So here's a list of the most commonly affected joints. I mentioned the hips and the knees, but the lower lumbar and cervical vertebrae are susceptible to developing osteoarthritis. So we're talking about here and here, just areas that can experience a lot of force, and poor posture on a daily basis doesn't help either. Looking at the next examples, we have the proximal and distal interphalangeal joints. So remember that the phalanges are the fingers. Phalanges are also the toes. This part here, these are not your fingers. This is part of your hand, just like this is part here, part of your foot. The phalanges, you can see that the four fingers here have three different that are called phalanxes that make up our fingers. And then we have two as part of the thumb. And so, as stated on this slide, the proximal and distal interphalangeal joints of the fingers are predisposed. So the proximal joint would be here, and the distal joint would be here. Proximal and distal. So these are predisposed to developing osteoarthritis. In addition, the first carpometacarpal joint. So these are the carpals. The thumb side is where we start for number one. So this is a metacarpal and this is a carpal. So the first carpometacarpal joint right here is also predisposed to the development of arthritis. So your thumb joint that allows for the action of opposition. And then similarly, the first tarso-metatarsal joint. So these small bones are called the tarsals. These long bones here are called the metatarsals. And then, of course, our phalanges here, the toes. And starting on the big toe side for number 1, just like we start there with the thumb, the metatarsal here and this tarsal bone here form a tarsal metatarsal joint, and that's also predisposed to the development of arthritis. So for the most part, that was referring to the primary or really idiopathic form of OA, but what about secondary? Oftentimes when we talk about secondary forms of diseases, it's relating to some sort of condition that causes something, in this case, osteoarthritis. So for example, certain medications can stimulate collagen digesting enzymes that can break down the synovial membrane and lead to what's called secondary osteoarthritis. What about males versus females? The incidence of OA increases with age, we know, but it is more common in females. And to be just a little bit more specific, females are more likely to develop osteoarthritis in the hands and the knees. Men are more likely to develop osteoarthritis in the hips. Now notice at the top I have put a question mark beside non-inflammatory degenerative disease. Well, if we know that itis refers to inflammation, is this not inflammation of the joint? Well, OA has commonly been classified as non-inflammatory. However, it has been identified the presence of numerous cytokines and chemokines and other things that do imply that there is some sort of low-grade inflammation. However, there are other types of arthritis that are different than osteoarthritis. And we'll talk about rheumatoid arthritis and gouty arthritis today, where inflammation is absolutely evident and becomes a problem when it comes to the progression of the disease. But still on the topic of osteoarthritis, the primary pathogenesis in osteoarthritis is degeneration and then eventual loss and really this disordered repair of the articular cartilage. That's the cartilage that is found between bones that allows it to articulate or form a joint and move properly without pain and degeneration. Enzymes, in particular collagenase, ACE referring to an enzyme, this is an enzyme that breaks down collagen. So collagenase in particular is an enzyme along with cytokines that are going to destroy some of the structure of the joint, including proteoglycans, which are basically proteins that are covered in sugars. Proteoglycans are part of cartilage and other tissues, and they can provide hydration as well as the ability of, in this case, the cartilage to withstand some of the forces that it will experience, such as compressional forces. So the enzymes and the cytokines break down proteoglycans, they break down chondrocytes, which are the main mature cell type in cartilage, and these get broken down fairly early in the disease process, and collagen fibers get broken down. So the overall effect that we're going to see with these substances being exposed to collagenase and cytokines is that there will be excess water entering the cartilage, overall lowering that tensile strength that it should normally have. The chondrocytes or the cartilage cells being continually exposed to stress and enzymes, and proteoglycan levels decrease. These changes lead to increased remodeling of the articular cartilage, and there's this loss of what should be a smooth, frictionless joint. And so visually, if you were to look at the articular cartilage that's being damaged, visually what you'll see is that it takes on this grayish or brownish grayish color. And as the disease progresses, surface areas of the articular cartilage, the superficial components, are going to start flaking off. And then deeper layers develop what's called fibrillation, where the deeper layers end up with these longitudinal fissures that are present. And so the fissures almost look like these tears, these longitudinal tears that are seen within the deeper part of the cartilage. So overall, the cartilage becomes thinner, and it may be absent over some areas, leaving the underlying, what we can call subchondral bone. So this is the bone that's beneath the cartilage, subchondral, becomes exposed and unprotected, and consequently the unprotected subchondral bone can actually then start to become damaged. So if we look here, here's the cartilage undergoing the changes already described, and now if this is thinned and not functioning properly, or maybe it's not present in certain areas, then this underlying bone, this subchondral bone, is now going to be subject to additional stresses just from moving that joint because it doesn't have the cartilage there to protect it. This image is showing you normal anatomy of a joint. So the bone joint surfaces, the articular surfaces underneath the cartilage and the cartilage itself and the joint capsule are all in great shape. And the next slide will show you an image of the degeneration associated with osteoarthritis. So we finished off this slide talking about how that subchondral bone, so beneath the cartilage, is now exposed and unprotected because the cartilage has degenerated. And so what this will lead to is remodeling of the bone where we've lost this protective cartilage. And so the bone becomes more dense and hard. That's the description for the term sclerotic, where the bone is becoming very rigid and it's starting to lose its ability to do what it's supposed to do. Cysts can develop, that's shown here. And these cysts can actually start to get large enough that they communicate with those longitudinal fissures. Remember that fibrillation that I spoke to on the previous slide that occurs within the cartilage during degeneration? So it can start to communicate with that. And as the cysts get larger, they have this increase in pressure within them, and the cystic contents can be forced into the synovial cavity through those longitudinal fissures or those fibrillations. And so when this happens, it can actually break even more of the cartilage, the articular cartilage, on its way. And the articular cartilage, as it continues to erode, can start to form what are called osteophytes. And osteophytes are these spur-like bony projections. You can see one here. And these, by the way, are very evident on X-ray if somebody has them because they're bony formations that show up on X-ray. But they look abnormal. They look oftentimes pointed like a spur. And they can continue to enlarge big enough that small pieces break off, causing those little pieces to go into the synovial cavity, into the joint cavity, the joint space, and they can become a problem in terms of the function of the joint. And those are called joint mice. So once again, these osteophytes, osteophytosis is the state, the condition of forming osteophytes, can get large enough that pieces break off. Those pieces end up entering the synovial cavity, and they are called joint mice, and they can impact function. Some other effects that are seen is overall enlargement and deformity of the joint, as well as these nodules, in particular on the hands, that are called Herberding's and Bouchard's nodes, and we'll see those on an upcoming slide. Joint mice, as I said, can impact overall function, but they can irritate the synovial membrane. And when they irritate the synovial membrane, it can cause synovitis, so inflammation of the synovial membrane that normally produces synovial fluid. And it can also lead to joint effusion, so an increase in the amount of fluid within the joint that should not be there. The joint capsule can start to thicken. We can see that happening here. And it can even adhere to the deformed underlying bone, and that can contribute to limitations in overall movement. So limited motion, stiffness, immobility, and then the inevitable pain and tenderness. that usually comes along with dysfunction. So this is just comparing the two. We've seen both of these images on the last couple of slides. So on this slide, you can see different examples of osteoarthritis or the effects of osteoarthritis. You can really see the erosion and degeneration in the hip. Here are the nodes that I mentioned earlier within the hands that can be an effect from osteoarthritis in the hands. So bony bumps on the finger joint that's closest to the fingernail, as shown here, are called the Heberdine's nodes. And then bony bumps that are found on the middle joint of the finger through here are called Bouchard's nodes. So these would be good for you to be aware of in terms of the difference. These bumps can also occur elsewhere. They don't necessarily have a name associated with them in the way that these two do. So next time you're observing somebody that is maybe older that you know has osteoarthritis, you may be able to identify these nodules or these bumps that are present and know that they do have osteoarthritis in those joints. And that's because of the bony remodeling that's occurring in the phalanges here. Okay, this image here is of cartilage, and it's just showing some of the degenerative changes, including a subchondral cyst. So just beneath the cartilage surface on the bone, we have a cyst. Now I'd like you to put the topic of osteoarthritis aside now, and that's because it is largely non-inflammatory. Now we're going to be moving on to talking about inflammatory joint diseases, which are oftentimes just referred to as arthritis, where this inflammation of the joint becomes certainly relevant. Inflammatory joint diseases are characterized by damage or destruction in the synovial membrane or articular cartilage with evidence of inflammation and systemic signs of inflammation such as fever, increase in white blood cell count, malaise, which is a general feeling of being unwell. Anorexia is not eating enough food, leading to weight loss, and hyperfibrinogenemia. Hyper is a lot of something, emia is the blood, and fibrinogen is a clotting factor. So this is an abnormally high level of fibrinogen, this factor involved in clotting within the blood. Arthritis can be caused by infectious agents, or it can be considered non-infectious. And the examples of non-infectious arthritis include rheumatoid arthritis, ankylosing spondylitis, and gouty arthritis. We're going to be talking specifically about rheumatoid arthritis and gouty arthritis in today's lecture. The underlying mechanism of both rheumatoid arthritis and ankylosing spondylitis, even though they are different forms of arthritis, there is an immune reaction component as well as hypersensitivity, which is related to our immune system. Ankylosing spondylitis can cause complete fusion of joints, such as the spine, where somebody loses complete mobility of their spine. So it can be quite debilitating. Now to elaborate on rheumatoid arthritis and gouty arthritis, starting with rheumatoid. Rheumatoid arthritis is very different than osteoarthritis in that it is a chronic, systemic, inflammatory, and autoimmune disease. Autoimmune means attacking your own body. It does primarily affect the joints, but it can also affect other tissues and organs due to its systemic nature. Thinking back to the hypersensitivities that were discussed in Altered Phys 1, what we have with rheumatoid arthritis is the formation of these immune complexes that causes damage within inside the joint. And this happens in many joints at the same time. So unlike osteoarthritis that might impact maybe the left hip or the right knee, you'll typically see multiple joints affected at the same time. So you can make note that rheumatoid arthritis is a type 3 hypersensitivity. One of the signs of rheumatoid arthritis where it will be evident that the disease has progressed is something called ulnar drift. Remember that the radius is the long bone of the forearm on the thumb side, and the ulna is the long bone on the pinky side. And what can be seen with rheumatoid arthritis is this drift of the wrist position towards the ulnar side. So that's called ulnar drift. In terms of laboratory tests, there are certain factors that you can look for in the blood to determine if somebody may have rheumatoid arthritis. Rheumatoid factor are consisting of these two classes of antibodies, so IgG and IgM primarily. And in rheumatoid arthritis, these antibodies, which act as autoantibodies attacking oneself in this autoimmune condition, can attack the synovial fluid, forming those immune complexes described earlier. So these antibodies are altered from normal and are called rheumatoid factors. So when looking a little bit closer at the pathogenesis of rheumatoid arthritis, we know it's an autoimmune disease. It's an autoimmune disease usually of a genetically susceptible host. And what triggers it? Well, some sort of antigen, but what is it? Is it environmental? Is it infectious? Who knows? But in any case, what ends up happening is the activation of CD4 helper T cells. So T cells are activated and probably even some B cells. And the chronic release of these substances or activation is what ultimately is going to lead to the joint destruction. Cytokines also play a role. They are key mediators in synovial damage. Now, T cells that are activated, these are going to stimulate macrophages and fibroblasts, which can play a role in the production of rankle. And we talked about rankle from the perspective of osteoblasts, the cells that build bone, that they produce rankle, which will then bind to a rank receptor found on the osteoclast to activate the bone-breaking cells, osteoclasts. But rankle can be produced as well by some immune cells, which can activate the osteoclasts. And if we're activating osteoclasts when we shouldn't be, it can lead to joint or bone destruction. Now, B cells can also be activated. And whenever you think of these cells, you're thinking of antibodies. And this is where the formation of rheumatoid factor occurs and that hypersensitivity reaction that causes those immune complexes to form, which cause destruction to the joint. Enzymes, we talked about collagenase with osteoarthritis, but collagenase and other enzymes are going to be released that in the quantity that they're released are destructive to the joint. And so what are we going to see? We're going to see joint destruction. We talked about the ulnar drift here. There's also going to be pannus formation. Now, when there are cytokines present, they're going to convert the synovium, the synovial membrane, into this thick abnormal layer of granulation tissue. And this thick abnormal layer of granulation tissue, thanks to the cytokines, is known as pannus. And pannus actually really behaves like this local tumor, locally invasive tumor. Cartilage can become fibrotic and ankylosis can occur. The term ankylosis specifically refers to this abnormal stiffening and really immobility of the joint. And then in this image here, you can see a normal joint compared to one that is inflicted with rheumatoid arthritis. the pannus formation, that thickening, which almost acts like a tumor. You can see the immune complexes as well as the different immune cells that are also present. Now on to a new topic, but still referring to inflammatory joint diseases. We're going to look at gout. Gout is an inflammatory response to excessive accumulation of uric acid. This uric acid can accumulate within the blood, where we would call it hyperuricemia, high levels of uric acid in the blood, but it can also accumulate in other body fluids, such as the synovial fluids of joints. And so the crystals can form, and these crystals have a name that's mentioned on the next slide called monosodium urate crystals, or MSU. The accumulation of these crystals can occur within connective tissues. They can also occur within joints, and when they accumulate within joints, it's known as gouty arthritis. It's more common in males over the age of 40, and the most common location for you to make note of, which is also shown in these images here, is the big toe. More particularly, it's within the first, which is the big toe, the first metacarpal phalangeal joint right here. And really, any metabolic disease that somebody has that leads to an increase in uric acid in the blood can predispose somebody to the development of gout. So high levels of uric acid in the blood can cause the formation of these crystals called monosodium urate crystals, MSU, within connective tissue, but also within synovial fluid. This is going to stimulate an immune response where we'll see the presence of immune cells such as neutrophils, leukocytes, and monocytes, as well as the proliferation of fibroblasts and synoviocytes. Now, when the immune cells act to phagocytose and try to clean up the monosodium urate crystals, what they end up doing at some point is rupturing and spilling out the content, which damages the tissue and further promotes inflammation. Now, diet can lead to the development of gout in some individuals. Anytime we take in purines within our body, which end up coming from meat when we're trying to break down meat, as an example, dietary purines, as well as any that are just formed within our body as part of metabolic processes, these purines can be converted then into uric acid, and normally we would excrete it through our intestines and through our kidneys. But if there's too much of it, then it increases within the blood and it can deposit itself into tissues. So it's like we've overloaded our body and we cannot properly clear it out. There are 3 clinical stages of gout: asymptomatic, so lack of symptoms, asymptomatic hyperuricemia. This is when the serum levels of uric acid is elevated, but the arthritic symptoms and some of the other signs that you would see are not yet present. And some people can persist in this state for a very long time. Next clinical stage of gout is acute gouty arthritis. These attacks develop when the levels of urate concentrations increase quite a lot, leading to the inflammation described earlier. The third clinical stage of gout is called tophaceous gout. This is considered chronic disease. And so people with this condition have experienced progressive inability to properly excrete the excess uric acid, and it continues to expand, and the crystals start to deposit themselves into cartilage and synovial membranes and tendons and other soft tissues. And when they deposit themselves into these connective tissues, it is called tophi. That's the tophaceous gout, tophi. And you can see that present in this person's hands. Now, on the last slide, I had mentioned that the most common location is the big toe, and you might be wondering why. Well, uric acid is sensitive to temperature changes. And at cooler temperatures, uric acid is more likely to turn into these crystals. And since the big toe is a part of the body that is furthest from the heart, it would be considered the coolest part of the body and therefore a more likely target of gout. This here is a chart that compares the 3 types of arthritis that we discussed, remembering that these 2 here are inflammatory and osteoarthritis is sort of in a category on its own. Now moving away from the topic of arthritis and looking at a condition called osteomyelitis. We still have that term itis, so there is inflammation, but this condition is a bone infection. And it's most often caused by bacteria. However, fungi and mycobacteria, parasites, and viruses can all infect bone. But the most common bacteria would be Staphylococcus aureus. Staphylococcus aureus, or Staph aureus for short. Now, regardless of the source of pathogen, when we look at method of destruction, regardless of the source of pathogen, the pathologic features of bone infection are very similar to what you would see when other body tissue is infected. Inflammation will occur, and small terminal vessels, blood vessels, in the area of infection will start to thrombose, forming clots. Exudate, so a pus material, will form, and this can seal off the bone's canaliculi. Now, why is this important? Well, thinking back to normal anatomy, canaliculi within bone are these narrow microscopic canals that are found in bone, and what they do is they function to supply nutrients to bone cells, and they'll also help remove bone cell waste. These canaliculi can also allow for communication between bone cells, but if they're being sealed off, you can see why that would be a problem. The infection that has produced this exudate can start to extend from where it initially begun, extend into the metaphysis of the bone. It can also extend into the marrow cavity as well. Then from there, it could continue to spread where it starts to extend into the cortex of bone, as you can see happening here. Now, in children, it's more likely, just because of the different nature of their bones, to form what's called a sequestrum and an involucrum, which I'm going to define now. In children, when the exudate reaches the outer surface of the cortex, as is starting to happen here, it can cause the periosteum, that outer layer of bone, to start lifting off the bone. Lifting of the periosteum, which we know is a vascular structure, is going to deprive the underlying bone of its blood supply, leading to necrosis and death of that area where the infection is, and it produces what's called a sequestrum. And the sequestrum is really just an area of what is sometimes described as devitalized bone or just dead bone. Now, lifting up of the periosteum can also stimulate this intense osteoblastic response. Remember, osteoblasts build bone. And so the osteoblasts will just start laying down new bone in the area around the infected bone. And this layer of new bone that's surrounding the infected bone is called an involucrum, new bone formation. So please make sure you're aware of these differences. Now, unfortunately, openings within this involucrum can cause the exudate to escape into surrounding tissue and ultimately even through the skin. Now, involucrums in particular are quite rare in adults because the periosteum is very firmly attached to the cortex. And so instead of an involucrum forming in adults, it causes just weakness overall of the cortex of bone, and that can predispose the bone then to pathological changes. Somebody could have a pathological fracture, for example. There are different forms of infection of bone. In other words, let's say it's a bacteria that infected the bone leading to the osteomyelitis. The question is, well, how did the bacteria get there in the first place? So it can get there through an exogenous route, an endogenous route, or a hematogenous route. And the hematogenous route sort of links in with this endogenous route, as you'll understand in a moment. We've talked about exogenous and endogenous in altered physiology before. Exogenous is meaning that the infection enters from outside the body, so from the exterior, EX. And so let's give an example of an open wound and the tissue in the area gets infected and it's not treated properly and it ends up spreading over time to the underlying bone. And this we talked about a bit in cases of diabetes where an infection can cause the bone to become infected. Endogenous osteomyelitis occurs when a pathogen, such as a bacteria in this example, is within the blood from a site of infection elsewhere in the body. Hematogenous osteomyelitis is a form really of endogenous, and this one is much more common in children. And what happens with this situation is we have an infection that spreads from the blood vessels in bone to the adjacent soft tissues. So it is really a form of endogenous because it's occurring within the body, or begins rather within the body. So the more common route would be the exogenous osteomyelitis, where that infection enters from outside the body from, say, a wound that gets infected. Clinical manifestations can include acute and chronic inflammation depending on the specific pathogen and the current state of the person with the infection. Fever, pain, and then necrotic bone can occur. You obviously want to catch the infection before the bone actually dies. Here are two examples showing you osteomyelitis. This is a chronic case, this blackened area with necrotic tissue, and then resected bone from a person that had osteomyelitis. Bone marrow is a really rich environment for bacteria to grow and spread. Just kind of as a side note there. The pathogenesis of acute osteomyelitis can differ depending on age. So to give you a couple of examples of that, to orient you first though, this is a bone and that's a bone and here's the joint. There's the joint space. This would be the diaphysis of the long bone, and this would be the epiphysis, and then this would be the growth plate. In infants that are younger than 1 year, the epiphysis here is nourished by arteries that penetrate through the physis, which is the growth plate, allowing for an infection here to spread to here. But once children get older, then the infection is actually restricted to this area because we no longer have the epiphysis being supplied, which is part of the reason it is this way here is because of the growth that's occurring. But then once that growth begins to cease, then the arteries are no longer supplying the epiphysis, and so the infection would be restricted to the area, in this case, the diaphysis. However, even though in this example, it can cause it to spread to the epiphysis and then into the joint capsule, just because it can't do that the same way when children get older doesn't mean it's not going to disseminate and spread elsewhere. If the infection does reach the joint itself, then it can lead to an infectious arthritis. Now onto the topic of bone tumors. Bone tumors, just skipping down here for a moment, can be primary or secondary. Primary means it originated in the bone. Secondary means that it's spread from somewhere else to the bone. So for example, somebody with prostate cancer, in certain situations, it can spread to the bone, and so that would be considered secondary, a secondary bone tumor, or metastatic bone tumor. Bone tumors can be benign or malignant. Now, primary malignant bone tumors are overall considered to be quite rare. It's more common for cancer to spread to the bone than to form in the bone. And benign bone tumors are overall far more common than malignant bone tumors. Primary bone cancers as well as secondary bone cancers can be evident because of pathological fractures that occur. And we talked about that during our in-class lecture. Primary bone cancers oftentimes will present with some sort of pain, swelling can be present, and then if it progresses, a pathological fracture. Some of the primary cancers that can spread to bone include prostate cancer, which I've already talked about, breast cancer, lung cancer, kidney cancer, and thyroid cancer. It's not very common at all for colon cancer to spread to the bone. Here's a list of the different forms of primary bone tumors that can exist. Now, the type of bone tumor is going to depend on which cell type that tumor arose from. And so cancer of the bone can arise from osteoblasts, bone building cells, chondroblasts, cartilage building cells, fibroblasts, collagen producing cells, and cancer can also arise from various different blood cell precursors that are found within the bone marrow. There are 3 specific ones that we're going to talk about today. Osteosarcoma, which you should be aware arises from osteoblasts, chondrosarcoma, which arises from chondroblasts, and then Ewing sarcoma, which arises from blood cell precursors in the bone marrow. The most common bone tumor in children is a Ewing sarcoma. The most common malignant bone tumor in adults or adolescents would be the osteosarcoma, and this can metastasize to other areas of the body, including the lung. And it does oftentimes result in amputation if it hasn't spread yet. So we'll see on the next slide that if somebody has an osteosarcoma in their leg and it has not spread anywhere else, the leg is oftentimes amputated in order to prevent inevitable spread later on. This is the cancer that Terry Fox had, and his leg was amputated in hopes to prevent spread, but in his case it did spread to his lungs. The final thing to mention or really remind you of is this term sarcoma, which we've talked about before, in particular in Altered Phys 1. Remember that sarcoma means cancer of connective tissue, and bone is a connective tissue. Now to talk about a cancer called osteosarcoma. It is the most common malignant bone-forming tumor. It's more common in adolescents and young adults, so a very devastating diagnosis for families. Osteosarcoma is very aggressive. It has this moth-eaten appearance when you look at the bone pattern, the way that it's destroyed, and the borders of the tumor are very indistinct and they kind of merge into the adjacent normal bone. So you can see how it appears here. 90% of osteosarcomas are located in the metaphysis, so the ends of long bone, especially the distal femoral metaphysis. So that would be distal femoral metastasis would be this region here. So that's a common location. So really the knee area. Now the tumor typically impregnates or invades the cortex of the bone, causing the periosteum, that outer covering, to lift up, forming this almost soft tissue mass that's not covered by normal bone, and we can see that here. The lifting of the periosteum stimulates this really bizarre pattern of new bone formation that is oftentimes described on X-ray as being a periosteal reaction. Clinical manifestations include pain and swelling that does worsen over time, increased pain at night, and this can be troublesome because it's not entirely uncommon for children to have growing pains at night, but it needs to be a consideration if there is pain and swelling that's present. And then if it does progress, it can cause pathological fractures. So if we look close, we can see it here, the periosteal reaction. The term osteoid means like bone, and it really is just unmineralized bone tissue, and it is normally a key structure in the development of mature mineralized bone, but there are masses of this osteoid tissue that form as part of the disease osteosarcoma. Chondrosarcomas are another common primary malignant bone tumor, and it's more commonly found in middle-aged and older adults. It is described as this large, ill-defined malignant tumor that infiltrates particularly trabeculae that are part of spongy bone. And it produces cartilage-forming cells, hence the chondro part, chondro referring to cartilage. So it produces cartilage-forming cells without ossification, so it's not forming bone. It appears most often in the metaphysis or the diaphysis of long bones, more commonly seen in the femur and the humerus, but it can also be seen in other areas as shown here, including the pelvis. And these tumors have the ability to implant and invade the surrounding tissue. Local swelling and a dull intermittent pain that gradually intensifies and then becomes constant is a common presenting complaint. And like a lot of cancers, it can cause the person to wake up at night due to pain. And as you can see, in certain cases, anytime a tumor is close to a joint, it could infiltrate that joint space. Ewing sarcoma is a malignant called a round cell tumor of bone and soft tissue. It's one of the more common types of malignant tumors that are found in children, but it is the most lethal bone tumor. It occurs during childhood, so the most common period of diagnosis is between ages 5 and 15, so another devastating diagnosis for those affected. In terms of the clinical manifestations, it can present similar to osteosarcoma. Pain and swelling can be a big one, but sometimes there are some other clinical manifestations that can occur with really all cancer types, including fever and just a general feeling of being unwell and anorexia. With this cancer, metastasis is very likely. It can spread to almost every organ within the body. Remembering back to the flow chart that I showed you earlier that showed that Ewing sarcoma arises from cells within bone marrow. And what can happen is it penetrates the cortex of the bone from the bone marrow, and it forms this soft tissue mass. And you can see how it looks here. And the most common locations of this cancer are shown here. It is more typical in the diaphysis, as you can see here. Diaphysis, the shaft of long bones. So this is showing you the femur, and this is showing you the tibia. And it can also occur in some flat bones as well. That's the end of today's lecture. Thanks for your time.